I would like to issue a welcome to the MUSC class of 2019. It was a pleasure last week to lecture to you on periodontal plastic surgery, and I promised there would be a video coming on how to do the initial exam. Because the initial exam is unique to MUSC, for it was designed there, and now it is my pleasure to go over that with you. So here we start on the initial examination in periodontics, MUSC class of 2019. And you will notice that I'm no longer at MUSC, but have accepted an appointment as a distinguished visiting lecturer at NYU. The first thing that you want to do before you get into step number one is you want to do an initial soft tissue exam looking for cancer and things like that. Before asking the attending for a starting check, the first thing you should do is share whether the patient needs to be pre-medicated, what the blood pressure is, and the typical things that are being currently done in the clinic. But the thing that you would also need to tell the attending is, does the patient smoke? Do they have diabetes? Because these are two factors that will need to have you refer to the backside of this paper, where you will come up with the prognosis based on the Miller-McIntyre Periodontal Index. As you do your exam, I would suggest that you get a fellow student and help them with your charting on that, and therefore it will go much more rapidly. The first thing you want to look at is the tissue texture. Do we have redness? Is there edema? Is there a loss of stippling? Do we have a fibrotic response? Do we have an absence of knife edge margins? Is the tissue enlarged? And do we have blunted papilla? Now, on your initial exam, the first one or two you do, you may want to call in the attending and have them go over this and show you what it is. The next thing you want to look at is the tissue of the gingival tissue. Now, this is extremely important and is not well understood by most dental students. When you see an area, you want to look to see if you do have attached gingiva. You want to know if you have unattached gingiva. Do you have a frenal involvement, or do you have an absence of gingiva as well? This will give you a clue as to possibly the need for a root coverage graft or flap or something of that nature. Finally, on the right, we look for, is there clinical attachment? Clinical attachment loss includes the sum of the recession, the probing depth, and the bone loss. And in doing this, you will note at the bottom that in probing, you don't gouge the patient necessarily. You only use the weight of the probe, which is about the weight of 10 pennies, and you actually just feel around the tooth, trying to feel to see if there's calculus, trying to see what the probing depth is, and then we're going to go to the second step, quantitatively doing bleeding on probing. Now, I have found over the years that most dental students don't have a good understanding of this, and you, the class of 2019, I think are going to be the exception. Now, with slight bleeding on probing, this is a trace. Notice that it is delayed, and what this indicates is a minimal inflammatory response. For example, if you're probing the distal of number 18 and you get no bleeding, then you probe number 19, and by the time you get to number 20, you see that a little blood is oozing out. That's probably not clinically significant, but dental students tend to say, well, yes, I've got generalized bleeding on probing. Moderate bleeding on probing is where you get spontaneous bleeding on probing. And this means a greater inflammatory response, which means the more significant the disease. Now, what this is, let's say that you have a 5 millimeter probing depth. And after you have probed the depth, as you withdraw the probe, some blood oozes out. Now, that would be moderate. Severe would be as soon as you touch the tissue, it begins to bleed and bleeds profusely, and it may be even somewhat difficult to stop. So this is the way that we quantitatively determine bleeding on probing, and that is the next step. And so when the attending comes over, you need to explain exactly what this is. One of the things also unique to MUSC is a treatment-focused diagnosis. Certainly we can have health, we can have gingivitis and periodontitis, but what I would like for you to focus on is health with attachment loss. This is a new concept that is not being taught in any other dental school except ours. What this is, let's say a patient has had periodontal surgery and you look at the x-rays and there's 50% bone loss, and unfortunately many restorative dentists and prosthodontists base their diagnosis simply on x-rays, and they will say that this is severe. But if you look in the mouth and you find that there is no bleeding on probing and there is no probing depth, what they have is attachment loss with health. And so this will prevent you from overdiagnosing and perhaps condemning teeth that are periodontally healthy. Gingivitis, remember, this is a reversible diagnosis and is usually associated with plaque and calculus, but there is no attachment loss. Finally, a periodontitis means that we have attachment loss, and this can be generalized or localized. It can be slight with probing depths that are around 5 millimeters, moderate 6 to 7 millimeters, and greater than 7 we would call severe. So a typical diagnosis that you will see in the clinic is a localized gingivitis in the mandibular anterior area with localized periodontitis in the maxillary posterior area. Now that tells you exactly what you're going to do in treating. You're going to do scaling in the mandibular anterior. You're going to polish well to get any stain off, and then you're going to give the patient oral hygiene instruction, and if they actually do that, this is totally reversible. With a periodontitis, remember, you have attachment loss, and this is where you do root planing. And if the case has 5, maybe 6 millimeter pockets, you know that this is not a surgical case, given that it's a localized periodontitis, and that it should respond to root planing. And with good root planing and removing of the accretions, as well as good oral hygiene by the patient, typically you can shrink these pockets a couple of millimeters. So if you have a 5, you should strive to get that probing down to a 3. If you have a 7, get it down to a 5. But I think this tells you that you can actually give a treatment-focused diagnosis if you give the proper diagnosis. The treatment options. Certainly with health, you evaluate oral hygiene instructions, you scale and perhaps remove any calculus, and go ahead and polish. If you have a gingivitis, it's exactly the same treatment, but you're going to do some scaling and you're going to want to reevaluate. Finally, with the periodontitis, you're going to give oral hygiene instructions, you're going to scale, and you're going to polish, and you're going to root plane, and then you're going to reevaluate. Now, it's very important to realize that 90% of the bacteria are removed by brushing the teeth, and that is on the facial, the occlusal, and the lingual. 40% of the bacteria removed from the tooth in flossing is on the mesial and the distal. But this is what is significant. 90% of the remaining bacteria are found on the posterior 1/3 of the tongue, and this needs to be addressed by using a tongue sweeper. We also need to think in terms of the predisposing factors, etiologic factors. Notice the number of those that can be eliminated. Defective restorations, overhangs, things like that, open contact, food impaction, uneven marginal ridge, ill-fitting prosthesis, and smoking or smoking tobacco. And these are totally under the control of the patient. Plunger cusp, intraoral jewelry, because a nail through the tongue can literally destroy the gingiva on the lingual or the lower anterior, and any occlusal discrepancies. But notice how many of those can be eliminated. We also have certain ones that we control. Yes, we can give good plaque control, but plaque is going to come back every day. Calculus is going to reoccur, and then we need to look at systemic factors that complicate the problem, such as calcium channel blockers that cause tissue overgrowth and other medications that may have a drying effect on the mouth. Obviously, you need to control caries, and you need especially to control class 5 interproximal caries. And also, we can alter the diet and also the toothbrush trauma. The final thing on the treatment planning sheet is how to treat bad breath for Dr. Gordon Christensen, who has published several articles on this in the American Dental Journal, has found that this is the third leading thing that patients are concerned with behind periodontal disease and caries. So let's outline how you should deal with this with the patient. Please be aware that after you brush and floss, using the tongue scraper, or the tongue sweeper as it is referred to by Dr. Robert Rippich, is designed to remove the bacteria on the posterior third of the tongue. Very importantly, these are sulfur-forming bacteria that give off the smell of rotten eggs. Now, the reason I like this tongue sweeper is because it's the only one that I have ever used that gets way back in the mouth without gagging you. Dr. Rippich was an engineer before he went to dental school, and this is very well designed, much better than any other tongue sweeper that I've used. Certainly you cannot use a wet toothbrush to do this, for that will gag you. Even gaggers can use this well because it is so well designed, it gets exactly where you want to go. And what you will find the first few times that you use it, you'll get a slime off the back of your tongue, and your mouth will immediately feel cleaner. And if you use this with the mouthwash that is recommended on the website, which is the most effective, cheapest mouthwash you can use, this even adds to the sweet breath. So the information that you want from Dr. Rippich is the tongue sweeper, where you have a website to go to, or you can call the 800 number below. Now, I have negotiated with Dr. Rippich to sell you these as a class for $4 each. To the patient, they cost $7. So, Kevin, I hope that you will contact and take class funds and buy one for everyone in the class to see just how well this works. So this concludes the presentation that I had on the treatment focused exam and so forth. I'm sorry I will not be with you to help implement this, but as you saw earlier, I will be moving on to NYU. But as I told you at the lecture on periodontal plastic surgery, I'm available to talk with you at any time you want to call. I will be happy to give some webinars to you at no additional charge, because I love MUSC and I want it to have the excellence that it should deserve. And remember, this is my website.